I'm coming with a different context. And I want to start by defining what is menopause, premenopause, postmenopause. Menopause is just a cessation of periods. Your periods stop. 1 year, no intervention in terms of family planning methods or other drugs being used. It is a natural phenomenon. You were young, you had your ovary, at puberty you start your menses, and you begin to acknowledge you can be reproductively active. By menopause, periods stop, your reproductive clock has closed. But it's not always an aging process. I want to put this very clearly. You have those who will go into premature menopause. Why? I'm on cancer therapy. Or I have done surgery on you, especially when you've had conditions like endometriosis, deep-seated endometriosis. You've got scarring on that ovary. And I may be forced to even move it out, or the interventions of surgery just cease it to function. And this can happen very early, ladies and gentlemen. A 34, 40-year-old. Or you had a hysterectomy and we say, your ovaries were not looking too healthy, I had to come out with it. What have you done? You've crushed the estrogen production. And principally, that is the hormone that keeps all these ladies looking very beautiful. Very beautiful. It's your estrogen. Then come through the natural process of aging. The ovary is reducing the production of that hormone, but the body clock is beautiful. You start beginning to gain weight between the lower part of your chest and the upper part of the lower part of your pelvis. Why? That fat tissue is actually a compensatory mechanism to produce the estrogen you need. So when you start gymming and you start finding this isn't quite going away, it is because that's a compensation happening. And then you have the lady who, in the premenopausal, which can happen anything between 5 and 10 years before menopause, which you now know, and then the postmenopause is about the 10 years after ceasing the menstrual period. That's the period. We call it climacteric. Please don't confuse it with my sexologist. But that's the period in which really hormonal replacement therapy can make a difference. I hope we're getting it very clear. Now, what happens with the lady who has premature ovarian failure? And especially noting it may be a much younger girl or lady. I have to start complimenting her. Why? Why do we do this? You've talked about the brain fog. And Honorable, I really liked your story because we go through it. I'm still on pen and paper to date, just to make sure I get it right. But you have the brain fog if unaddressed as a result of menopause and your happy hormones. He was talking about happy hormones. We don't want to get too technical. But there's some happy hormones that dance. Your dopamines, your serotonin, they're beautiful hormones. I mean, the milieu, the environment the brain is bathed in, that keeps you a happy soul. Now, when menopause comes and estrogen goes and your happy hormones decline, now you begin to see those mood swings, temperaments, concentration deficits. In its worst, we talk of Alzheimer's or the dementia, which he has to deal with, which families have to grapple with. So that's one big problem you would wish to avert. You have to start upstream. The other is cardiovascular disease, heart problems. The other one is now the bones that creak and you begin to behave like a robot. When you're asked, stand by Nelly, give me time. When it's really on a bad day and cold like it is, You can see some of us are wearing very warm clothes, eh? Not out of choice. You want to keep warm because those bones are not moving as agile. A lot of people will present with fractures. Any small fall or displacement, it just snaps because the bones have weakened and cracked up. So those three things, the bone issue, the brain issue, the heart issue. But let's compound this. This is also the age we're beginning to see diabetes raising its head. We're beginning to see cancers raising their head. So you have other cocktails of things that may surround this particular time phase. And then you have the relational issues. I don't have to belabor to that. But your partners, your children are leaving the nest in a lot of the families, particularly in your post-menopausal year. And for women, there is a give that has to happen. And sometimes it's very painful. So, what is the role of HRT? Simple. I'm replacing particularly estrogen. That's the main hormone. But I also have to know, do you have a uterus or not? Because if I bombard you with just estrogen, I may actually end up giving you a predilection, let me use the word predilection, to getting cancer of the lining of the uterus. So a lot of us will give a combi pack of estrogen and progesterone. So some people will get cyclical withdrawal bleeding. A lot of women don't want that. I'm done. And this is the reason we've progressively reduced the doses of those drugs so you don't end up with a period that you had ceased having. Why am I mentioning this? If after menopause, you're being followed up whether you're on HRT or not, you're getting post-menopausal bleeding, it could be heralding a problem, particularly cancer of the reproductive system. I don't want to say just the uterus. The uterus can have cancer. The ovaries can have cancer. The vaginal lining, even the cervix, they all give us postmenopausal bleeding. So when you have menopause, please, any woman, the first thing you need to know, if my periods return and they had stopped, that's a red flag. I hope we're together. Now, I'll advance it even more. Testosterone. We have an amount of testosterone we release as women, particularly in your mid-cycle during your reproductive years. And we do use testosterone supplements, particularly when you have issues with libido. Low dose. But we know you have to have it monitored by your doctor. Too much of anything is a poison. We're in an era, and I really like the fact, Goko, you went up north. Climate change, environmental toxins, we don't talk as loud, but we know it is beginning to even affect our endocrine, our hormonal environment. So we've got to start paying more attention. So I'm not surprised she gave the story she's given. The sense is there. Do we have HRT in this country? Public system? No. And I hope, Honorable, you're noting. Yes, we have our essential drug list in this country. Estrogen has actually been put in place, and if you look at the latest publication of 2023, it has even been given an indication for hormonal replacement therapy. The progesterone, we have some tablet, but we do not have definite HRT medications are 1, 2, 3, 4, as I've alluded to. Okay? So we are wanting private system, private insurance, and particularly the really beefy ones. You may be able to access the medications, am I right? But these are the girls with premium package. What do I do with Mama Mboga? What do I do with the lady in the rural village? So some of the things people are misusing, and please put it loudly in the airwaves, are family planning tablets. That is wrong. That is wrong. Because family planning tablets have got different preparation, which has got much higher doses, which have a wrong effect to your system. HRT is just that, hormonal replacement therapy. Much lower dosage and either given consequentially or cyclically. That's one. Do we have testosterone preparations? Nada. So what have women recourse to? And I think all the ladies in this house will be very familiar. We take alternative medicine, cocktail. And I wouldn't mention names, but pyramidal schemes do exist. Yes or no? Do we know them, ladies? And you're told, okay, you can take red clover, you can take evening primrose, you can take, I can go on and on with these alternative herbal and natural things, including soya. Now that one everyone knows. Soya. They do have a role, but to be honest, have we done proper research to look at it in our context? Nada. The other thing I must mention, Honorable, and this concerns me, is all these things that have raised their heads we're not talking about. The Botoxing, the fillers, the facial lifts, the breast augmentation, the liposuction. Now you've understood where I'm coming from? Question is, what is the regulatory framework that we have? And is it right? We have even seen calamities that have happened, haven't we? So we've got to think holistically and not just at HRT, because this is also a time self-image becomes a problem. And women definitely always want to look nice. At 80, I want to still look good, Dr. Monda, don't we? So that's what I would want to say about this question. Conflicting information, misinformation, disinformation, inappropriate sound knowledge. The second one, how can we improve access to safe, affordable HRT in Kenya? We've talked policy, policy, policy. Policy is not operational. We must have guidelines. We must have algorithms. I've talked about the woman with or without the uterus. But we have to add layers. In some women, before you even give hormonal therapy, find out the family history for breast cancers. Find out if she's already having post-sexual contact bleeding, which may actually be heralding that there is a problem at the cervix. So you must look at the patient history. You must know how this patient is through laboratory investigations. Now, the laboratory investigations, I'm coming to insurance because she's seated here. It's a whole bombardment of investigation. I need to know your BMI. I need to know your lipid profile. I need to know your sugar. I need to know how your thyroid is behaving, because they all have a bearing. Now, that cocktail of tests, honestly, Honorable, it is impossible for Mama Mboga to afford it. It is impossible. But it must be done, because some of the drugs have got a bearing on the liver. And I need to know how it is. I may be on other treatments because I am a diabetic or I'm a hypertensive. So you have to look at that. Then we have the issue around choosing the route of the medications. Increasingly, we're moving away from you gobbling it up. We want to use transdermal, so patches, gels, creams, because they don't affect you elsewhere. They work where they're supposed to work. So we have to be able to decide with the individual. It is individual. So I come again to Honorable, and I come again to Evelyn and to Nellie and to Angela. Do we have well women clinics? I've always said, where is the Golden Girl Clinic? It doesn't exist. I'm over 50. Where's my Golden Girl Clinic? So that I can have this executive screening and checkup. Most of us stop when we stop giving birth. That's it. I never see you again. And when I do see you, I'm dealing with rheumatic problems, brain problems, cardiovascular issues. They've already set in. And even then, they may not ask about your menopausal or your gynecological history. So, well, women clinics. Because really, we've got to start having an entry point at all levels of care for women so that we can begin to have this conversation. Monitoring and follow-up. Please, I don't want you to leave here with a blanket that everybody can go onto HRT. Some of us did not experience hot flashes. I don't know what it is. Some have nightmares. I will not mention who is asking me, what do I do? Yeah? So some have nightmares. But every woman experiences a transitory issue. This is an ideal time to even do screening for particularly reproductive cancers, and please do not forget the breast screening, which we really say start at 40 if you haven't done your basic mammogram. So we have admins that can add value for our women, and therefore it can improve access and safety. We have endocrinologists. Gynecologists ideally should be dealing with this entity because it's a continuum of her care. But endocrine people tend to come in because we tend to see them for diabetes, for my hypertension, for my thyroid problems. So that's a complementary group we should be working together with. Mental health, we should be working with. So when I'm talking about a well woman clinic, it should be multidisciplinary. Must be. Reviews, follow-up, 6 monthly to begin with, and then yearly, if you have no problem with your HRT. HRT does not go on forever, amen. For some women, they'll use it for a year. For some women, 3 to 5 years. For others, they may have to use it a little longer. It's individualized. I don't want you to go there with a blanket. Then, what safeguards should I plan to have to ensure safe prescribing? That's the easiest question to answer. I have a policy framework. I have guidelines. I know how to actually put an algorithm on any woman. Screening, diagnosis, management. And I want to bring in the male because honestly, you are partners and allies in this war. You must walk with us, understand us, have public education forums, have forums where we also undertake localized Kenyan research. So here, I'm even looking at Ministry of Health. Mary is here, Magumbo. I know you'll get the message to my friend. Yeah? We have to start a registry on menopause. We don't have. We just don't have it. And what's not documented is not. Yes. Number 2, we have given too much leeway to the quacks. I'm sorry to say. The quacks. Wherever there's a hiatus, you don't fill it, somebody will come up to fill that space. So those commitments there, honestly, I will be prepared to run. Because menopause has been a neglected area. And it has to change. I'll leave it at that.
Oh.